Picture this. You're a clinician evaluating a patient, right? You place your stethoscope right over the apex of the left chest, exactly where you've done it literally 1,000 times before. You're waiting to hear that familiar rhythmic lub-dub. But instead, you hear nothing. Not a muffled sound, not a distant beat, just absolute, terrifying silence. And that absolute silence? Well, that represents a moment of pure, visceral panic for most trainees. It's the moment your mind starts racing, thinking about massive effusions, catastrophic events. Or maybe you're just tempted to hastily scribble "heart sounds inaudible" in the chart and move on. But the correct response here is definitely not panic. Actually, it's one simple, absolutely crucial, almost reflexive physical action. You just move your stethoscope a few inches to the right side of the chest. So where's the heartbeat? Because in the 2 seconds it takes to slide that stethoscope across the sternum, you might just go from a confusing, totally silent physical exam to cracking a massive medical mystery. Finding that heartbeat on the right side reveals dextrocardia. But as you'll see today in this explainer, locating that right-sided heartbeat is just the very first domino to fall. It can lead you to a single, unifying diagnosis that explains not just the heart's position, but the patient's chronic cough, their childhood ear infections, and even their fertility history. All of it stems from one single event that happened before they were even born.
Okay, let's dive into this. Here is our roadmap for today's explainer. First, the bedside mystery. Second, the organ blueprint. Third, the cilia connection. Fourth, 2025 guidelines and diagnosis. And finally, modern trials and therapies.
All right, part 1, the bedside mystery. Okay, so we've moved our stethoscope to the right, and boom, there it is, a strong, clear heartbeat. We've confirmed dextrocardia. But here's the most important concept to grasp right out of the gate. Dextrocardia is rarely just about the heart. I mean, sure, dextrocardia simply means the heart is sitting on the right instead of the left. But treating this like some isolated cardiac quirk, that completely misses the big picture. The position of the heart is just one visible marker of a much larger, systemic process. Finding it should instantly trigger a huge question in your mind. What else in this patient's asymmetric anatomy is mirrored, or worse, completely disrupted?
Which brings us to part 2, the organ blueprint.
To answer that question about what else is disrupted, we really have to explore the concept of situs. Basically, situs is the early embryological left-right patterning that dictates the arrangement of absolutely all of our asymmetric organs. The heart, the lungs, the liver, the spleen, even the rotation of the gut. They don't just independently decide where to go. They all develop their asymmetry together in perfect unison, driven by the exact same early embryological signals. It's like a giant biological puzzle. Now, this organ blueprint comes in 3 distinct patterns, and knowing the difference between them is literally a matter of life and death. First, we have situs solitis. That's our normal reference point, heart pointing left, liver on the right, normal gut rotation, the usual setup. Then we have situs inversus sotalis. This is a complete, perfect mirror image. Heart on the right, liver on the left. The clinical stakes here, surprisingly low. When it's a complete mirror image with no other structural issues, organ function is totally normal. These patients live completely normal lives and, honestly, often only find out about their mirrored organs during a random routine physical. But then there's the third pattern, situs ambiguus or heterotaxy. This is the dangerous, chaotic pattern. It's a failure of the embryo to cleanly commit to either a normal or mirrored arrangement, so you get this highly unpredictable mix of left and right-sided traits. The clinical stakes here are incredibly high because this pattern is heavily associated with complex congenital heart defects and severe splenic abnormalities. We're talking either lacking a spleen entirely, which is asplenia, or having multiple small dysfunctional spleens known as polysplenia, and that carries massive immune consequences. So a right-sided heart is totally benign in isolation, but potentially life-threatening if it's part of a chaotic heterotaxy.
Moving on to part 3, the cilia connection.
Think about this for a second. Embryonic left-right signaling on one hand and respiratory mucus clearance in the lungs on the other. What could these two vastly different biological processes possibly have in common? Well, this is the massive aha moment of our entire explainer. The exact same tiny hair-like cellular motors, our modal cilia, that sweep mucus out of your lungs, are the very same structures that drive the left-right fluid flow in the early embryo, which establishes normal asymmetric organ placement. Mind-blowing, right?
So when these cilia are broken, we get a condition called Primary Ciliary Dyskinesia, or PCD. It's an autosomal recessive disorder where these modal cilia just fail to beat effectively. During embryonic development, if the cilia aren't beating to create that directional fluid flow, the embryo loses the mechanism that guarantees normal left-sided heart placement. The outcome becomes completely randomized. It's essentially a biological coin flip. And this is exactly why roughly half of all patients with PCD end up with normal organ placement, while the other half wind up with situs inversus.
When a patient gets that specific coin flip of situs inversus combined with primary ciliary dyskinesia, we call it Kartagener Syndrome. This presents as a superclassic triad: situs inversus, chronic sinusitis, and bronchiectasia, which is that progressive airway damage. The sinus and lung issues happen because, as we now know, those broken cilia can't clear out mucus, which leads to constant repeated infections. The crucial point here is that this exact same ciliary defect isn't just confined to the chest and the head. The fourth element of this is male infertility. See, sperm flagella use fundamentally the exact same structural machinery as respiratory cilia, so impaired sperm motility is a major yet frequently totally missed consequence of this underlying genetic defect.
Part 4, 2025 Guidelines and Diagnosis.
Before we even think about ordering a scan, the physical clues are right there at the bedside if you know how to link them up. Imagine our patient from the start, the one with the silent left chest. We found the heart on the right. Now we listen to their lungs, and we hear coarse crackles that shift when they cough. That's the classic sound of bronchiectasis. We look at their hands. We see finger clubbing. We ask about their history, and they describe endless wet coughs and severe ear infections, or otitis media, since they were a kid. This isn't just a random string of bad luck. These physical findings point instantly to a unifying diagnosis of a systemic ciliary failure.
Once we suspect it, how do we confirm it? Well, we are no longer relying on the old, invasive, and unspecific methods. The 2025 European Respiratory Society and American Thoracic Society Joint Diagnostic Guidelines have formalized a really precise, multimodal pipeline. Step 1 is a fast, non-invasive screening tool, measuring nasal nitric oxide, which characteristically plummets in PCD patients. Step 2 moves us to the microscope, specifically high-speed video to actually watch the cilia's beat pattern, and transmission electron microscopy to look for physical, structural defects in the cilia themselves. And finally, Step 3 is modern genetic testing. We now know of over 50 genes that cause primary ciliary dyskinesia. This allows us to confirm the diagnosis on a molecular level and provide absolutely vital genetic counseling for families.
Finally, Part 5, Modern Trials and Therapies.
And this brilliantly illustrates how we've evolved, because the year 2024 marked a massive turning point. Historically, since we couldn't fix the broken cilia themselves, we were sort of stuck just treating the downstream consequences using generic bronchiectasis management protocols. But now, we're finally entering an era of targeted therapies.
Now, of course, foundational management still absolutely requires rigorous airway clearance techniques and aggressive antibiotic treatment for respiratory exacerbations. But we are moving way beyond just symptom management. Because we recognize the systemic nature of the disease, we also now proactively offer fertility counseling and assisted reproductive services for these patients. But here's the really exciting part. In 2024, the CLEAN PCD trial specifically evaluated a drug called idurafluoridide. It's an epithelial sodium channel blocker being tested specifically for primary ciliary dyskinesia. This is a huge leap forward. We are developing disease-specific therapies for a genetic condition that, until very recently, only had generic treatments available.
So, let's pull this whole beautiful, logical chain reaction together. A silent chest, it's merely the first clue. Moving your stethoscope reveals the heart on the right. Recognizing dextrocardia prompts you to step back and look at the overall organ blueprint. You check for the dangerous heterotaxy or the benign complete mirror image. If it's a mirror image, you investigate the microscopic motor, the cilia, that flips the coin of our anatomy in the first place. And a broken ciliary motor doesn't just flip the heart. It traps mucus in the sinuses and lungs, and it halts sperm motility. 3 totally distinct organ systems, one underlying cause, all pieced together simply because you didn't panic at the silence. You moved the stethoscope and you knew the first principles.
And that leaves me with a final, provocative question for you all to think about. What other supposedly isolated physical findings in medicine are actually just the tip of the iceberg, serving as clues to massive systemic genetic mysteries? I really want to hear your thoughts on this. If you enjoyed breaking down this medical mystery, please drop a like on this explainer, leave your answers and comments down below, ask any questions you have, suggest what complex topics we should tackle next, and most importantly, hit that subscribe button so you never miss out. Keep learning, and I'll see you in the next explainer.